So those of you who don't know me, my name's Nikki. I am the co-chair of the Musculoskeletal Research and Practice Network. I'm a physiotherapist by background, and I feel quite passionately about trying to advance the standard of care that we're delivering here in Newcastle. So as a group, the steering committee and the group behind the Research and Practice Network are driving some novel ideas and ways that we can all come together and connect and share ideas and summarise some evidence and try and overcome some implementation issues that we might be having here in Newcastle, so ultimately the patient benefits from what we're doing. So thank you all for coming and for participating in this. And yeah, we look forward to continuing to deliver these events in the future. So I want to thank our sponsors for this event. So the University of Newcastle, New South Wales Regional Health Partners, Clarity Imaging, Innovus Rehab and the Orthopaedic Clinic, who without their support we wouldn't be able to run these events without the significant cost associated with it. And I also want to thank our presenters who've volunteered and donated a lot of their time and effort to put the content together for this evening. So just a little round of applause for all of those people involved. Thank you. And I also just want to acknowledge the traditional custodians of the land on which we are meeting tonight, the Awabakal people, and pay my respects to the elders past, present and emerging, and to any Aboriginal and Torres Strait Islanders people meeting with us this evening. The next big event of these that we will be having is likely going to be in October. The topic will be Achilles rupture, which should be good, and we have some people with us this evening that might be heading that one up. And then for those of you who are involved in our case presentation nights, the next one will be on August 14th at Newcastle Sports Medicine, so keep an eye out for those. And then a later one at Advanced Physio in November. We try and create a bit of a safe space for these events, so the whole purpose is that we're all trying to get better and we're all trying to learn, so there are no silly questions. It's a safe space to make mistakes. So don't criticise individuals, just their ideas, and allow everybody a chance to speak and make sure you all listen before talking over the top of people. So I'm going to introduce our speakers for this evening. We are very blessed with some local talent here in Newcastle, so it's my pleasure to introduce Dr Ross Cairns, who's a sports and exercise physician from Newcastle Sports Medicine. He is wearing lots of hats at the moment, and he's a lecturer here at university. He's the Chief Medical Officer for Northern New South Wales Football. He works with Football Australia. He coaches football. Used to play football. Still play football? He runs a busy practice. He's a dad, which he reckons is probably the hardest job of all of them, and he's stupidly taking on a PhD. Just kidding. No, looking at heading in football. He's passionate about high-level individual, ethical, medical care, and providing that to all people, not just elite athletes, in an evidence-based manner. Virgil Chan, who we might have seen at previous events also as well, he's completed his radiology training here at the John Hunter Hospital in Newcastle and then went over to Vancouver to do his musculoskeletal fellowship. So we're very lucky to have Virgil because he's one of a small number of musculoskeletal radiologists that we have here. And he's spent many years doing diagnostic and interventional radiology at the John and has just transitioned into private practice at Clarity Imaging. And Virgil's focus is mostly around spinal imaging and intervention. And a new format and a new person that we have with us is Rebecca Haslam. So in the past we haven't had dietitians, but I'm very, very happy in this topic to invite Rebecca to come and talk to us. So Rebecca did her undergrad nutrition and dietetics here at Newcastle and was awarded her PhD in 2016. She practices as a sports dietitian and runs her own private practice, which is called Nutrient Nation, and is a casual academic here at university. She works with athletics, swimming and the winter programs at the AIS, and is the nutrition lead for the Athletics Australia, where she drives lots of strategic direction around nutritional programming. She has a passion for working with athletes with Red S, which we'll be talking about a bit this evening, and working with multidisciplinary teams to help athletes achieve their performance goals. Kelly was very bad and didn't get me a bio, so I made it up for her. She's a physiotherapist at Newcastle Performance Physio. She's a co-host on the Sports Medicine Project podcast, where she also works to break down barriers between research and clinical practice. She's a keen runner herself and loves treating running-related injuries. She has also experienced a few running-related bone stress injuries herself, and now has a special interest in bone stress injuries and in the female athlete. How'd I go with that? That was pretty good, I thought. We're very grateful to be able to showcase these local clinicians here, very thankful for their time, and I want you to have a think about the things that they talk about in their discussion, and then hold some questions for the end in the discussion. We are also very privileged to have Dr. Greg Lovell with us. So he's actually online in Adelaide at the moment, so he's zooming in. So welcome to Greg. He's a sports and exercise medicine physician as well. Oh, there he is. Hey, Greg. He's a fellow of the Sports Medicine Australia and an adjunct associate professor at the University of Canberra. He has extensive experience in high performance sport, including elite football codes, Olympic sports, and he's had 15 years at the AIS. He's got a special interest in groin pain and in bone stress injuries, and he developed the Bone and Sports Physician module for the Australasian College of Sports Physicians. So any sports physicians who've gone through their training would know Greg's content in developing that module. And so, yeah, have a think about some interesting questions that you might have for all of our panel members, including Greg, at the end. So, just quickly, Ross is going to cover some of the medical stuff relating to bone stress injury, including pathophys, risk factors, history exam and medical management. Virgil will come and talk about some imaging considerations and show us some of those examples of how to grade bone stress injuries. Beck will be teaching us a bit about understanding energy availability and nutritional considerations for these athletes. And then Kelly will come in and talk about how bones respond to load, and then how we can apply that in a clinical situation with rehab. So I'm going to invite Ross up to come and talk he's going to speak in 3 times speed. He's got a lot of content to get through.
Beautiful. All right. Hey everyone, how you going? So, got a fair bit to go through this evening, and I think it's important to understand that this is a huge topic, and we're really just scratching the surface with what we're talking about today. So it's a bit of a whistle-stop tour, and there's going to be gaps in the information. So questions in the panel afterwards welcomed. We're going to try and get through a few things. So the general structure, we want to understand what normal bone is, then have a look at how that results in stress injuries developing, and what risk factors and physiological influences are there to contribute to bone stress development, and then look at the assessment of those injuries, what we do to treat them, and some special types of injury as well that we need to look at differently. Just separate to my talk, the reference here, Honig in Nature. If there's any one paper I think you should read about this topic, it's this paper. It's a really good overview of stress injuries, and will cover almost everything we talk about tonight. Maybe not in high detail, but a really good paper to read if you want to follow up on all this. So with bone, I don't want to get too caught up in the microscopic structure of bone, but the main thing to understand is that bone it's a living tissue. It's constantly changing and evolving. And it's made up of cells, where you've got your osteoblasts, your osteoclasts, osteocytes, and they are responsible for turning that bone over. You then have collagen that forms the structure of your bone, it's the scaffold, and then you have your mineral, your hydroxyapatite, that gives the bone rigidity. But it's not a structure that stays the same, it's constantly changing. And that, it's homeostatic, and the cells all have an interplay to have that homeostatic environment. There's signaling between those cells, and they all have slightly different roles. We have mechanoreceptors in osteocytes, we have osteoblasts that form bone, we have osteoclasts that resorb bone. Now they do more than just that, but broadly that's their role. Now, as a normal physiological process, we have bone modelling and bone remodelling that occurs. So bone modelling is broadly a trophic process where there's extra bone laid down, there's a change in shape, size, structure of that bone, so it can respond to stresses and strains and adapt positively. We also have bone remodelling, which is part of that is in response to our hormonal system to try and maintain our metabolic needs, things like our calcium levels. But the other part of bone remodelling is to try and identify areas of injury, normal injury as part of life and activity, and to repair it. There are 3 broad types of micro damage that occur in sort of daily life activity. There are micro cracks. We have a coalescence of very small micro cracks called diffuse damage, and trabecular microfractures. And I suppose the main thing to understand about that is that when we look at stress injuries, and they will be a combination of different types of microdamage. So there's a different healing process in each stress injury we see, and in each bone we see, in each part of the bone, whether it's trabecular or whether it's cortical. So it's a complex mechanism of injury and healing that we don't really fully understand. All of these processes, they require energy to be functional and working properly. So, as a basic view of what a bone does in response to load, we have some micro damage that occurs. We then have this remodeling process with a synergy of osteoclasts and osteoblasts that then result in repair of the bone. We get some remineralization and we have a healthy bone again. And hopefully with some bone modeling as well, we get a positive adaptation, which is why some people can run many, many kilometers without an issue, because if they've slowly, over time, exposed their bone to stresses, it remodels and becomes stronger and better for it. The problem is that you can overwhelm that healing process. So you get this accumulation of microdamage, a bit like tendinopathy, this similar sort of thought process. The microdamage accumulates until it reaches a point that you get coalescence of microdamage and you can get pain, and you can then progress on to macro fractures and complete fractures. That's a really simplified model. There is a lot more interplay with various signaling molecules, Rankel and osteoprotegrin, and things that are beyond the scope of this talk. But I think as a broad overview of thinking about stress injuries, that's a good way of considering it. So it's accumulation of microdamage. There's lots of factors outside of the bone that influence that healing process and the health of the bone. We've already got the hormonal calcium environment in interplay. We've got the effect of growth in various groups. We've got the sex hormones. We've got energy that's available for that healthy system, and the influence of exercise. So we'll touch on each of those. So calcium, obviously is very prevalent in bone. It's where 99% of our calcium store is. But the main role of calcium in our body is not for our skeleton. It's actually in cell signaling pathways, it's in coagulation, it's muscle contraction. It's got some really important physiological roles. So our body uses the skeleton to maintain our serum calcium. That's the primary role. So when you have a blood test to look at calcium and it's normal, all that's telling you, it doesn't tell you you've got a good calcium intake, it's just telling you that your interplay of vitamin D, parathyroid hormone, and your skeleton is intact to maintain serum calcium. The physiology, I did have another slide in here that we removed, but it was basically to say it used to bring me out in cold sweats, and I don't think for the purpose, from a clinical perspective, you need to fully understand the interplay of how vitamin D gets activated. But you do need to understand that vitamin D is a hormone, essentially, that is crucial in maintaining calcium levels. It helps keep calcium in the body from reabsorption in the kidneys. It helps increase calcium absorption from the gut. And it is regulated partly by parathyroid hormone and partly by calcium. It predominantly comes from sunlight exposure. We do get a little bit in our food, but unless you've actually got dedicated supplementation, the amount of food is relatively negligible. And we know if you have low vitamin D, there is a slightly higher risk of bone stress injury. Interacting with that, we've got parathyroid hormone that comes from your parathyroid glands. That also helps keep calcium in the system. It also protects that serum calcium at all costs, so it's crucial in resorbing bone from your skeleton. And to have normal parathyroid hormone responses, you have to have adequate levels of magnesium. Now that's relevant from a dietary perspective, but also if you are doing blood tests, there's something to consider as well. Growth is obviously only relevant to very specific groups, but there is a spike of stress injuries in adolescents. And the reason for that is there is a mismatch between the peak velocity of bone growth and the peak velocity of bone mass, well, not velocity, but peak bone mass accrual. So you tend to grow before you increase your bone mass, which means you have this transient osteopenia, which increases the risk of bone stress. And during that growth phase, we see that there's actually an odds ratio increase of risk. So if you are looking after any teams or youth teams, and you're monitoring growth rates, this is one of the reasons where you might look at modifying training volumes, because there is a true risk of injury, and not just bone stress, but there is a physiological reason for it. You need to give those kids a chance to adapt. I won't go through this too much because I think Kelly's going through some of this, but the effect of exercise on bone. There's a couple of key elements is that bone will put on more bone mineral density and mass in response to spikes of load. So you need to exceed a mechanical threshold, and it's not just the load, it's the rate that load is applied. So a spike of load is more osteogenic than just a slow load exposure. So jumping, for example, is a very good exposure if it's done in the right volumes. If you do too much of it, you stop getting an osteogenic response. The bone gets saturated, it doesn't respond. And we know that if you can break up that load into smaller portions, well, certainly in animal studies, which is where most of this has been done, and healthy bones, not necessarily abnormal bones, we can see an improved response to that exercise. So in this bar chart, all the subjects are exposed to 360 units of load, and it's broken up into either 1, 2, 3, or 4 bouts of activity. And you can see as you break up the bouts interspersed with rest, you get an increasing osteogenic response. So we don't know the optimum rest time, but if you break up load, it seems better. Estrogen, and I mean, testosterone is also relevant to bone health, but has been much less studied. We know more about the effect of estrogen. It inhibits osteoclast and stimulates osteoblasts for bone formation. And we see that people that have prolonged ovulation time in their life, so early menarche and a later menopause, have higher bone mineral density in general. And after the menopause, bone mineral density starts to drift quite rapidly. So estrogen is really important in bone health. One of the things I think is really important for everyone to understand when you're seeing a patient, though, is that being on the pill is not protective for bone health necessarily. In fact, a lot of the studies would suggest it's harmful if there is an energy availability problem going on that the pill's masking. And that's for a few reasons. I mean, you'll see a lot of patients who actually have menstrual irregularity, and that's why they're put on the pill. If that irregularity is because of an energy deficiency problem, being on the pill then just masks it because they think they've got regular cycles. But it's not. That's an artificial manipulation, and the underlying reason for that irregularity may not have been addressed. The reason that exogenous estrogen doesn't necessarily help bone health is that it gets processed through called first pass metabolism, and it has a negative effect on IGF-1, which is also positive for bone health. So taking estrogen orally is negative for bones, but transdermal estradiol, which bypasses that metabolism, actually may be better, and there are some studies that support that, which we'll touch on later. Again, Beck's going to go through this in detail, but energy availability is a really important risk factor for development of bone stress injuries, and it's not exclusive to females. It's in both sexes. It's just harder to assess in males. And broadly, I think people have always thought, energy in versus energy out is all you need to look at, but that's not quite right. It's energy in minus energy out. It needs to have something left over so you can maintain your normal physiological processes. And if that leftover amount of energy, your energy availability, drops off, you start to get dysfunction in your physiological mechanisms. And there's a few cut-off rates based on some science that Beck will go through. But it's important to understand that it doesn't just affect your menstruation, it doesn't just affect estrogen, it affects multiple hormonal systems. There is an increase in your stress hormones. There's a direct effect on that bone homeostasis that I mentioned requires energy, so you get stale bone that becomes more vulnerable. And that's reflected in the very high increased risk of bone stress injury in amenorrheic athletes versus eumenorrheic athletes. But it also affects your cardiovascular health, and it affects your immune system, which influences training because you're more vulnerable to infection. Probably the least important part of that slide is it affects sports performance, except that's the part that will get buy-in from most of your patients, because everyone who has a stress injury is normally an over-exerciser, and sometimes that's just because they like running a lot, but often it's because they're pushing harder and harder for more performance. So if energy availability is low and there is poor sports performance, it's an area where you can try and get buy-in from your athlete. Because we've got good data on this. We know that the more training availability you have, it correlates with success, whether it's football tournaments, whether it's Olympics. That training availability is a key predictor of success. So if you have more injury and illness because your bone doesn't recover and your muscles aren't recovering, then obviously you're going to have less performance. But also that low energy availability to the point that you've got disruption of your menses, your periods, has an effect on direct training adaptation. So there's a really good study on swimmers, and they took a group of people with functional amenorrhea and put them through the same training program as people that had normal periods, so eumenorrheic. And after that 12-week period, 12-week time frame, too many periods in that, for instance. So the people that had normal menses, they had an improvement in their times by 8%, but those that were amenorrheic actually had a deterioration in their performance by 10%, despite exposure to the same load. So, I mean, that's a really great way of getting people on board because, you know, if you're going to train, you really want to get the adaptation. So, you know, thinking of those things, that they all translate into what the risk factors are. The number one risk factor is really your training exposure, the amount of exercise you do, but it's not the absolute volume. It's about changes in load. Because bone adapts, if you adapt well, you should be able to tolerate good loads of exercise, but if you have sudden spikes in your training volume, then you haven't adapted to be able to tolerate that, and you are risking that accumulation of micro damage. So the devil's in the detail. When you see a patient with bone stress, you need to really look into the frequency of their exercise, how intense it is. You know, is it hill running versus just running on the flat? Have they taken up a new sort of activity? Is it a different surface? I mean, running on a flat surface versus a trail exposes the body to a lot more stability load and transfers stress to different parts of that bone. So simple things like that can be the primary trigger for developing bone stress. I've put footwear in here not because it's a key factor, but it's something to consider that's extrinsic. You know, there's mixed data on whether you need cushioning or orthotics or barefoot running and the profile of injury that you may get. But coming back to change, the biggest issue is if you suddenly remove an orthotic or if you change your footwear type to something different, you're exposing your foot and the rest of the kinetic chain to a different force that it may not have been adapted to. So intrinsically, the bone mineral density that we've talked about. Virgil, I didn't see if you were talking much about DEXA scans at all, but in my experience, I very rarely see a low bone mineral density in people with stress injuries. And there's a couple of reasons for that. I mean, people who are exposed to impact activity tend to have a higher than normal BMD compared to age-matched populations. But what BMD doesn't look at is the microarchitecture, the actual scaffold of your bone. And the scan that looks best at that is this higher resolution quantitative CT, which isn't in mainstream use, but maybe in the future, but will probably give us a fair bit more information about bone stress and bone quality. Endocrine function, we've touched on. Nutritional status, we've spoken about, is key to look into that. Your growth rate, make sure you get the information on it. It can be hard to get good info, but you need parents to tap in. And if you see patients over their life cycle, always get their height and weight of their kids, because you're likely to see them again if they trust you, and you'll get an idea how they're tracking. We know genetics has a role, including ethnicity. There's much higher rates in females, like 2 to 3 times the rate of stress injuries compared to males. And non-Hispanic whites apparently have much higher rates, which I wasn't aware of until preparing for this. And biomechanics, they're relevant. But for me, I think aren't the key factor for bone stress. I want to know about it. I want to know if there's a clear weakness and a side-to-side difference and asymmetry. But I don't think it's usually the cause of a bone stress injury. But if you identify a problem, it makes sense to address it. And running cadence is a risk factor for stress injuries. The lower your running cadence, the higher your risk of stress injury, and it's probably because of the spike in load versus more steps per minute. So I don't want to teach you all how to suck eggs here, because all of you know the presenting complaint part here. It's a very classic story of focal pain that comes on without trauma, that if you ignore it and carry on exercising, you start to get pain with normal daily weight bearing, and a whole bunch of people have night pain, but not everyone. And there's usually a change in your training volume or on the surface, or there's a growth spurt. So I think most of you in this room have a good awareness of that side of things. But the right side of this slide is the niggly stuff that you need to find time to talk about and find the right environment to talk about, because probably talking about periods when there's just a curtain between you and the next person isn't the best environment, but it's information that needs to be gathered. And it's the detail. When did their period start? Is it the same as their mum or their sister? Like, is it close, or is there a warning sign there that there's a problem in place? Loss of libido, loss of morning erections is a bit of a soft sign, but it's one that you need to ask. Couldn't resist, sorry. There's no hard science to back that up. But it is a historical point that we think, because it's hard to detect in men, if you have lower testosterone, it seems to be related to loss of morning erection. So, not an easy question to ask, but it's one of the few things that we can ask of males to try and identify low testosterone. Our average consult, we can't do a detailed dietary assessment, but I think it's easy enough to get a rough idea over a couple of minutes if someone has very low carb intake, if someone avoids dairy, if they've had fad diets or they've been exposed to really low energy diets in the past, because they're all going to increase the odds of being a problem and will trigger saying, well, I need more information here. I need to get them to see someone like Beck to actually get the full detail. And then don't forget comorbidities and medicines, because they influence bone health as well, particularly things like glucocorticoids, so steroid inhalers, course of prednisone over time, previous fractures, which predicts future fractures, one of the biggest predictors. So that's all really key info to get. Again, left side of this slide is pretty clear. Stress fractures usually have focal pain. They have pain with hopping. There may be percussion or vibration tenderness, a weak sign. You may have a palpable periosteal reaction if it's been there for a while and it's superficial. But really it's that focal tenderness and hopping which are key, and if there isn't pain with hopping, the odds of it being a significant stress injury are very low. But think about relative negatives. Say you're trying to rule out other conditions and make sure you're thinking of that bone stress. So if there's pain on muscle or tendon stretch, it's probably not bone related. Same as if you're testing muscles isometrically in non-weight bearing positions, it shouldn't really aggravate a bone stress injury most times. And if the tenderness is quite diffuse, there may be other differentials like medial tibial stress syndrome, for example. On the right side, these are the things that you should bear in mind, because they might trigger, it's a sort of a red flag assessment really, where you need to get medical assistance. There are signs of eating disorders that can be picked up without having to ask those difficult questions. And I think when we talk about history, you may not ask some of these questions the first time you meet a patient. I mean, you're trying to build trust, and if you start asking them about do they eat enough and how are their periods straight up, they may not come back. So you've got to sort of tread carefully, but there might be signs here that trigger your your senses quickly. So hirsutism, getting this sort of fine vellus hair on the face and arms, can be a sign of low body weight. These marks on the knuckles from bulimics can be a sign that they're inducing self-vomiting, as can tooth decay from gastric contents damaging your teeth, and wearing baggy clothing to hide their body shape as well. Other endocrine diseases can be identified, things like proptosis with thyroid issues. And I've put iron deficiency in here, which isn't, doesn't cause any bone stress injuries, but if you have nutritional issues, there's a good chance that there's going to be iron deficiency. So if you're seeing some of the signs with iron deficiency, that might pique your interest if someone's also got a stress injury present. So again, nutritional assessment is going to be key. Investigation-wise, beyond imaging, which is Virgil's bag, there's blood tests to look for bone physiology, and we want to look at the hormonal side of things. We have bone mineral density, which I've already spoken about, that it has limitations, and I think is frequently not helpful, but it needs to be done if you've got someone who's got high risk factors present or they've had multiple stress injuries. But if it's purely an overload problem and the rest of the situation looks pretty good, I wouldn't do a bone mineral density test on everyone. And in that dietary assessment, I think getting sports dietitian input for certain people is really helpful, but you don't want to send someone who's got an eating disorder necessarily to a sports dietitian, because that could send them down the wrong path of more food obsession. It's where you might want psychology, but in terms of assessing the diet, there are people that sports dietitians can be invaluable for. So my overall treatment paradigm is, once I've determined there's a stress injury present, I want to identify the best bone healing environment. Essentially, that bone needs to be pain-free, whether that's non-weight bearing or protected weight bearing, or just walking. As long as there's no pain, I'm happy. In general, I like to avoid immobilization because there's secondary downsides to that. We're getting joint stiffness, we're getting muscle atrophy, we're walking unusually because of new leg length difference. I try to avoid that if I can. But it's each circumstance is different, and sometimes it's just the way you need to go. But if someone's on crutches, I don't really see why you would need to be in a boot if it's a stable stress injury and you trust them to not put weight through it. Which, maybe a kid you'll put in a boot as well. These people are over-exercisers, so just telling them to not exercise isn't helpful. You've got to give them an outlet, otherwise they won't follow your treatment plans. They're cross-training and non-impact, swimming, cycling, rowing. Looking at that energy availability, perversely, there is a risk that when they're not exercising, they could gain weight, and that could actually create some issues as well. So you need to manage that environment very carefully. But it is your chance, when they are injured, to really look at their training load, to prescribe a return to training, to really educate them on how they should build their training volumes and how they should periodize and have rest, and get coaches on board and really understand why this happens so they don't have it happen again in the future. Address those muscle weaknesses and if they're present. I do add vitamin D and calcium to all of my recovering patients, even though there's no good science for it. And I tend to keep them on that until they're back to full sport, mainly because the risk of harm is almost absent. But there's plausible science to argue that it's beneficial, but it's not proven at all. And then there are some other adjuncts which we'll touch on. But that treatment paradigm is very different for a group of stress injuries, which are your high-risk stress fractures. And these stress injuries that really require a much higher level of concern and often urgent referral. These injuries tend to not heal very well. They have delayed union or non-union, or they can have catastrophic consequences if they do not recover. And the problem is usually because they have a poor vascular supply, or the stress injury occurs on the tensile side of the bone rather than the compressive side. So there's a distraction force, so the fracture margins aren't compressing together. So femoral neck, inferior femoral neck, not so much of an issue. Superior femoral neck, any stress injury there is an emergency. You need to be non-weight bearing or bed rest till they've seen a surgeon. These can go wrong even if you do everything right. We had one in the last couple of years. Lady was immediately put onto crutches, had a dynamic hip screw formed, went really well for 6 months, and then the femoral head died because it obviously had lost its blood supply at some point and ended up with a total hip replacement at 23. So it happens. Even when you do everything right, it happens. So these are really high risk injuries. You don't mess around with them, you get surgical input immediately. Anterior tibial cortex, stress injuries are on that distraction side of the bone, and they've often been present for a while, and you can see these dreaded black lines as they're referred to, which is essentially a non-union, and they struggle to recover. And these are the ones that you sometimes see on TV where someone has a catastrophic failure. Often it's a gymnast at the Olympics has pushed through some shin pain and they land and their leg snaps in two, because this just suddenly becomes not a partial fracture but a complete displaced fracture. I've had a few of these that I've treated with air cast brace and supplements and a bit of pulsed ultrasound, and they've come good. But I've also had a few that just don't, and depending on who it is, you may need to actually refer these for early surgical intervention, because some people it's okay to take 3 to 6 months to see how it goes. Some people it's not. So if they're an elite athlete, you're a manual worker, you might want earlier surgical opinion to consider an intramedullary nail, for example. The navicular is prone to avascular necrosis. It's very avascular in its middle third. It's really important to have a CT scan on a navicular. Even if the MRI says there's no macro fracture, so visible fracture line, you need to get a CT because it can miss them. I've seen that several times, and if there is a fracture there, you treat it very, very differently. They need to be non-weight bearing for 6 to 8 weeks, and they have a very slow return to sport program. This is again one of these injuries where the actual consequence of getting this wrong is huge. If you have a collapsed navicular, it can't necessarily be reconstructed surgically. And in fact, early surgical referral for this doesn't necessarily produce a better outcome. Surgeons aren't convinced that surgery helps this more than good non-operative treatment as well. It's a bit in between. But if you have a comminuted navicular fracture that doesn't recover, then your foot is, it's not working for the rest of your life. So this is one of those where you err on the side of caution because the consequences of getting it wrong are just too high. Whereas fifth metatarsal, a bit different, but fifth metatarsal is one of those that is prone to refracture. And if you've got the right person, you can, if you give them long enough, you can get union and you can get full return to sport. But there have been some good studies that show if you treat it early, that you get faster return to sport, faster return to work, less refracture rate, less delayed unions, non-unions. So early surgery for these is a good option. Again, depends on the person in front of you. If they're not on their feet a lot at work and they're happy to wait, they can. But surgery has been shown to overall produce a better outcome. And finally, this is the adjuncts now. The short story here is that none of this has proven benefit for stress injuries. But people with low vitamin D have higher risk of stress injuries. We have seen that estrogen supplementation with transdermal patches increases bone mineral density and microarchitecture, but that hasn't been translated into clinical changes as yet, but there is good physiological mechanisms of why it would be beneficial. There's these pneumatic air braces for anterior tibial stress injuries, where the first study that came out had these dramatic responses and people were back running within a few weeks, and those that didn't have it took several months, but a follow-up RCT showed there was no difference at all. So how do you judge those? I think sometimes you might use them because you're in a tricky case, and it depends if people can tolerate them. Do they need with the stirrup braces, you need that anterior panel, or if you've got a pneumatic boot, it needs to have anterior buttressing to combat that tensile force at the front of the tibia. Fortier, which is a recombinant parathyroid hormone, has has really good rationale behind its use, and there has been some really positive case studies, there's been good animal studies, but there's not large randomised controlled trials to support it. I do remember from Greg's module, which was excellent, he spoke about a few years ago about the AIS using this, and a number of athletes were able to return to sport faster than they would have been expected, and they would have missed major events if they hadn't tried this. So there is clinical experience out there in some of these tertiary centres that this could be appropriate, and it's probably something to consider in very certain circumstances, but it's not a standard. I give everyone 48 to treat them. I think the course of it is 28 days of injections, and it's about $500–600 because it's an off-label use. I have no experience using bisphosphonates. They used to be used more frequently for stress injuries. There are side effects with it. They are sometimes used for other bone marrow edema conditions with anecdotal benefit, but as I say, it's not something I've used for, and there's not much support for it in the literature. And then finally you have low intensity pulsed ultrasound, which has really good backing for your classic fractures, speeds up healing, helps non-unions, delayed unions, great data on that. But unfortunately, the data hasn't been shown to help for stress ease. Now, there's not loads out there, but there is good RCT done by a sports med registrar I went through a training with, actually, so he was very hopeful that it would show some benefit, but there was nothing. And the other study that looked at this was on PARS injuries, where it said it actually made a big difference to outcomes for return to sport. But they didn't let PARS stress injuries return based on clinical grounds, it was based on radiological grounds, and that's not how most of us practice. So although there was a big difference in their study, it probably doesn't reflect typical clinical practice. But maybe it does show that there is a benefit on bone healing rates in that circumstance. So for me, lipus, again, it's not something I use in everyone, but I do think in those difficult stress injuries, something that's not healing as fast as you want, or there's a time pressure to recover, it's relatively low cost. I mean, it's not cheap, but it's easy to apply, and I do use it for a number of stress injuries. All right, that's me.
Awesome. All right. Okay. So, shall we just keep marching on? No stretching. All right. So, I'm just going to go through very quickly some imaging considerations, like the other seminars that we've had before. We're just going to go through a few of those. As everyone knows, common sites for bone stress injuries or bone stress fractures, lumbar spine, femoral shafts. I mean, Ross has gone through some of the high-risk ones, but these are just most of the sites that we commonly see or have to keep in mind when we're dealing with bone stress. The easy part for me is that they really all sort of look similar, different parts of the body, but the same imaging findings and the same imaging appearances when we image them. So the main imaging modalities for bone stress that's most useful is, of course, MRI. Everyone loves MRI. CT, as Ross has already mentioned, in some situations CT is really useful, especially when I'll go through it looking for fracture lines. Plain X-rays can be quite useful, even just as an initial, commonly as an initial investigation. It's cheap, it's fast. And the other imaging modalities, which I won't go into too much, is bone scans. Bone scans are great, very sensitive. Obviously, I don't do bone scans. And also, you've got a really good modality in MRI and it's got no radiation, so I don't really see much point of doing a bone scan to look for bone stress if you don't have to give radiation. I put ultrasound there as a peripheral thing because sometimes it can be useful. It's not a direct investigation you would use, but sometimes it shows up, and it's something that can help when it shows up unexpectedly. And then the other thing I think Ross mentioned was DEXA, bone densitometry, DEXA and QCT. I didn't put it specifically just to keep the talk nice and short, but we can talk about in the discussion panel if people are interested about QCT and DEXA and the ins and outs of the two different types. So, as everyone knows, radiographs or x-rays, it's pretty poorly sensitive in the early stages of bone stress, 15 to 35% sensitive for detecting basically stress reaction or fracture. And it takes a while for bone changes to develop, for bones to remodel, for us to then to show up on x-rays. And it becomes a little bit easier and more sensitive in the later stages of bone stress injury. The most common x-ray for bone stress injury is that it just looks normal. And you'd be hard-pressed to find anything to say. But we talk about, if we're really good, if we're really on the ball, then we sort of, we sometimes see some loss of the cortical density. It looks a little bit fuzzy, the margins aren't sharp. Over time, with the bone remodeling, you get cortical thickening, it gets more dense and more sclerotic, and then to a stage where you can actually appreciate the cortical thickening, and that can take up to 2 weeks. And then the other thing is that obviously if we see a fracture line, then that's pretty indicative. CT is also very similar, it's just that we see it sort of, everything looks easier, it looks better demonstrated for those findings. It can help confirm the findings that you see on the radiographs and x-rays if you're not really sure. It can give you very good fracture definition if you wanted to look for a fracture. And also exclude other bone causes of the presentation, so making sure that there's no osteomyelitis or any underlying bone tumour that might be responsible for the presentation. MRI is probably the mainstay for investigations for bone stress or bone stress injuries. It's basically, we know, up to 100% sensitive. And it also helps differentiate from soft tissue injuries that can give you similar symptoms, similar examinations. The most important finding that we look for is bone marrow edema. So, everyone who's come across x-rays, we like looking for bright things, draws attention to our eyes, bright bone marrow edema, it's nice and bright on the MRI scans. We like to try to look for a fracture line because that obviously, as Ross says, has implications on management and prognosis. And what we also see on MRI is perosteal and soft tissue edema that goes with the injury. So I'm going to quickly go into a little bit of grading. I think this is, I'm not sure if everyone likes to use grading. Some people really want it, some people don't really want it, but Fredrickson originally published in 1995. It was specifically for medial tibial stress injuries, but since then people have just adapted to all sorts of bone stress injuries in all different parts of the body. And at least in the radiology literature, it talks about sort of how to, it gives you a sort of a prognostic indicator, I guess, to when you can go back to impact activity. And from what I can read in radiology literature, I'm not sure about clinical other sort of avenues, so I'm not really sure about how applicable this is. But basically, grade 1 injury is 2 to 3 weeks and go back to impact activity. Grade 2 to 4A is 6 to 7 weeks, and then 4B, which is the most important one, where there's a fracture line, it's 9 to 10 weeks or more, and I think we can discuss that, or someone else can tell me clinically if that's sort of on the right sort of time frame. But we'll go through these in a little bit more detail. So grade 0 is normal. So we'll start on grade 1, which means you just get a bit of edema on the periosteum, but there's no bone marrow abnormality. So just on basically on the periosteum on the outside of the bone, a little bit of edema and nothing in the middle. And then these are obviously getting more and more severe. At grade 2, you've got now periosteal edema, and you also have mild bone marrow edema, but it's only visible on T2 weighted images. This is how they classified it. So I'm just sort of going through with the way Fredrickson sort of classified these grades. But basically, it looks bright on the fat suppressed T2 weighted image if it's grade 2. If you can also see it on T1, then it's grade 3. And it's a bit subtle. It can be quite hard to differentiate whether it is actually visible or not on T1. But I guess at the end of the day, if you go back to the first slide, grade 2 to 4A is very similar sort of downtime, really. So it's probably not such a huge issue. Grade 4A, you're starting to get some cortical changes, and they talk about multifocal or several areas where you've got some edema. You've got lots of periosteal edema, so everything's adding on extra findings. And then you get lots of extensive bone marrow edema on T1 and T2, but also now you're getting some cortical changes as well. And then 4B, than actually seeing a fracture line, basically. And that's sort of what I sort of concentrate on, looking for a fracture line, because it makes it easier to grade. Then you just know that's just 4B, and we can move on and look for it. Just want to brush up on a few other sort of grading systems that come through. We can have a discussion about which grading system people use, but it's just little modifications. The ARENT system uses marrow change on stir sequence, which is a different sort of technical MRI sequence rather than the actual findings. And again, grade 4 is fracture line, basically. And then there's another system that came out in 2013, which, again, it's based on mild, moderate, and severe bone marrow edema with and without fracture lines. So they're all very similar systems. I think we use, I don't know, or we can talk about in the discussion panel what the preference is, but most people seem like Fredrickson, I think. Well, that seems to be most common. We can go through a few examples, and then this is a person who has bilateral leg pain, and you can see on the big coronal images, you've got a bit of bone marrow edema in the fibula, a little bit more prominent on the right side and left side, and when you do the axial images, you can see this is what we call periosseal edema. It's just that little fluffy white around the bone, but the cortex itself looks normal. So this is where grade 2 comes in, and then you've got a little bit on the right-hand side. The right fibula has a little bit of bone marrow edema in the bone marrow, so hence it's a higher grade. It's on the right, which is sort of grade 2, whereas sort of periosseal edema just on the left without as much bone marrow edema. You can just call that sort of grade 1 bone stress. Another patient, I thought the X-ray they had looked pretty normal, but what's quite interesting is when you do your MR, you've got quite a bit of focal bone marrow edema in the midshaft of the tibia. Now, this is where it gets a bit difficult. This is a T1 scan, and we don't like using T1 as much, or it's not as easy on T1 because our eyes are usually drawn to bright areas, and on T1 you're actually looking for greys and darker areas for edema. So this is the same area, but it's a little bit grey rather than normal white for bone marrow, which is mostly fat, and hence this becomes a grade 3. And on the axial, we can see that there's bone marrow edema, but no cortical edema. That's a grade 3 bone stress injury. This one's quite obvious on a plain X-ray. You can see that there's quite thick, well-formed periosteum, lots of bony remodeling from a injury that's happened a long while. There's really quite severe bone marrow edema on the fat-suppressed images in the tibia for a long length, and it's much more clear on T1 because it's so extensive and so severe bone marrow edema that it's actually, you can see that it's actually quite grey, quite obvious, and you can see the periosteal thickening is quite well formed. And then on the axial images, lots of severe bone marrow edema. This is that periosteal thickening, that new bone that's been laid down. But you can also see that that's got lots of abnormal signal around it. And then even around the periosteum, all the way around the tibia, you've got further bone marrow, further periosteal and soft tissue edema. So, and also, we're actually going to see a fracture line running through into the medulla. So this becomes a 4B injury. This is another patient who X-rays looked pretty normal, and we can see that they have bone marrow edema along the neck of the femur. You can see that this is a really subtle black line on the medial margin, which looks suspicious for a fracture line. Fracture lines can be sometimes quite hard to see on MRI, and so with the CT. With the aid of the CT, you can sort of confirm that there's a fracture line that obviously makes it a 4B, confirms that it's a 4B injury or 4B grading, and may require different sort of management options. This patient has really subtle changes that I can just barely make out on the fibular shaft, proximal shaft, and then I've just magged it up on the X-ray, and then you can actually see that there's a very fine, faint cortical line. So, I mean, this is very early periosteal thickening, it's periostitis really. It's what I would call peritonitis, and it's very subtle, and it's hard to see. If you think a good history, it's pretty hard to pick up sometimes. I think you can easily overlook it. But then obviously on MRI, you can see the fracture line, you can see the actual periosteal thickening, and you can see a lot of associated soft tissue edema as well. So obviously much better on MR. And this is one of those cases where sometimes you can see something on ultrasound, and this patient has some periosteal thickening along the second metatarsal shaft. There's a couple of undulate. Sorry, I thought I had a marker. I thought I had a pointer. Sorry. So there's a little bit of second metatarsal. There's a couple of little areas of focal periosteal thickening, and then when they just had an ultrasound booked in because it was just foot pain. You can see that on the ultrasound. There's a little breach in the cortex, which is basically that white line on the bottom of the image. There's a little breach through there, and when we put the colour on, which is basically looking for vascularity, it's really vascular around the area, and there's a lot of soft tissue swelling. And then that's confirmed on an MRI on the subsequent on a subsequent day. They came back, and you can see that the bone marrow edema is quite extensive. You don't see any of that bone marrow edema on any other modalities of MRI. Right. Here, sure.
Other dietitians in the room? Token dietitian, all right, no pressure at all. Okay, I will be focusing mostly on low energy availability, relative energy deficiency in sports, and then the contribution to bone stress injury. So I'm pretty happy so far that what Ross covered aligns with what I'm about to cover. It's always good when you align with the sports physician in the room. Just to start, a couple of definitions just to make sure we're all on the same page. So energy availability. So it's the dietary energy that is left over and available for optimal functioning of body systems after we account for exercise energy expenditure. So the body systems that we're talking about, heart function, reproductive function, thyroid function, etc. Relative energy deficiency in sport, or REDS, is essentially a flow-on effect of that, where we see impaired physiological or psychological consequences from more problematic low energy availability. And I'll discuss what problematic is in a little bit more detail. So in practice, energy availability is expressed in kilocalories per kilogram of fat-free mass. And it's defined by the formula you can see on the screen. So you can see the components that we need are dietary energy intake, exercise energy expenditure, and fat-free mass. So you can see from that there's probably already some limitations in our use of the formula, because we know there's inaccuracies in the data collection methods for dietary intake and exercise energy expenditure. The LEA cutoffs that I've got down the bottom, so males on the left, females on the right. So we can see that the female cutoffs are higher, and these values have been in the literature for a lot longer period of time. So the early research on low energy availability had more focus on female populations. The lower end at 30 kilocalories, essentially below that, is where we're seeing more of those physiological or psychological consequences. Above 45 is considered optimal energy availability. Males on the left-hand side, you'll be happy to hear in the room, cutoffs are lower, which essentially suggests that males are likely more robust or more resilient to low energy availability. The cutoffs, though, are really, they're still not a hard and fast cutoff. It's going to be variable from person to person at what point in that energy availability spectrum where they get those physiological consequences. So IOC consensus statement for REDS. So it was first introduced in 2014 and has had 2 updates since, so the most recent update last year in 2023. A lot more original research has been included, but there's still so much more that we need to learn around relative energy deficiency in sport. But the 2 models I wanted to point out, and look, you can't see the finer details on these models, but essentially the health conceptual model on the left performance on the right, and it really details what each of those components that are going to be impacted from a health and performance perspective with REDS. The point I wanted to point out though is the inner white circle in the middle with the red arrows. You'll notice there's a white section of shaded on the arrow, and essentially what they're trying to communicate there is that there's likely a level of low energy availability that may be safe, let's call it safe, without the physiological or psychological consequences. And when I think about that from working in practice, particularly with athletic populations, I know there's going to be times across the annual training calendar where I have to put them in low energy availability to manipulate body weight and composition. We don't yet know exactly what those cut-offs are, but I guess the cut-offs from the previous slide are really kind of that step toward trying to work out what that dose response might be, but probably worth a bit of discussion in the panel. So the etiology of LEA and REDS, so 3 main categories, and I guess these are sort of categories of clients or patients you might see that might be red flags for you to be referring on. So we've got our unintentional group, so a sudden increase in training load without consequent increase in dietary intake, or then we've got our adolescent group of athletes going through peak height velocity where we see a substantial increase in basal metabolic rate, and I'll touch on in a bit more detail about that. The misguided but intentional group, so they're attempting to manipulate body weight or composition, so they're putting themselves into a state of energy deficit. And then we've got our compulsive, so that's our disordered eating, eating disorders, and exercise dependence. So Ross touched on sort of peak height velocity as well, so we know that's the fastest upward growth in our adolescents, typically between 10 to 13 years of age. During this period of time, because of the growth of tissues, bones, organs, the literature suggests there's an increase in basal metabolic rate of up to 400 kilocalories per day. So over the period of time where that's happening, if the adolescent isn't increasing their intake to match that increase in expenditure, it's that period of time where we're really seeing the increase in risk of bone stress injury. Disordered eating, so we know that there's varied prevalence, but up to 19% in males, up to 45% in females. And highest prevalence is going to be in our aesthetically judged, our gravitational and weight class sports, because of the hyper focus on achieving particular body weights and composition. I wanted to include the spectrum of eating behaviours here, again, because across an athlete's sporting career, they will titrate along this spectrum probably a number of times. Hopefully we keep them from progressing to the red end of the spectrum to a clinically diagnosed eating disorder. But for the clinicians in the room, it's important to understand that you know what the red flags are when an athlete is potentially transitioning from the red to the orange, so that we can refer, so that we can intervene before it progresses to the red section. Exercise dependence, so no hard and fast definition here, but we're going to see the individual behaving compulsively, exhibiting withdrawal symptoms when they can't exercise, and we're going to see negative life consequences simply because of the extreme volumes of exercise. Prevalence, again, is going to be variable, but particularly in our athletic populations, endurance runners and ultramarathon runners are our highest prevalence for exercise dependence. So the role of low energy availability, or REDS, in bone stress injuries. I'll try to simplify this as much as possible, but Ross has pretty much touched on most of these concepts already. But low energy availability is essentially, from there, the hypothalamus is going to send signals to the rest of the body. The main body systems that are involved in bone health regulation are going to be adipose tissue, thyroid, and reproductive organs, where we then see changes to insulin growth factor 1, insulin, thyroid hormones, and testosterone and estradiol. From there, we then see decreased bone formation, increased bone resorption, and overall increased risk of bone stress injury. Again, I won't cover this in detail because Ross did already cover it, but essentially, as Ross said, the body's main goal is to maintain serum concentrations of calcium. So the things that are going to kind of disrupt this calcium homeostasis or lead to the increase in bone resorption is if an individual has inadequate calcium intake, and we're expecting that if we're working with individuals with low energy availability or REDS, they're also going to have inadequate nutrient intake as well. So if calcium intake's inadequate, bone resorption is going to increase purely to keep serum calcium levels in the right levels needed for homeostasis. Okay, nutrition interventions. So I'll come at this from two different angles. So what is the direct impact on bone health from specific nutrients? What is the indirect impact if we manipulate energy availability to improve hormone profiles to then influence bone health? My conclusions from these next few slides are very simplistic, simply because of the time frame of what we've got to present, but again, happy to talk to it in more detail in the panel. So firstly, calcium and vitamin D. So two studies on this slide. We'll start with the one on the left-hand side. It's comparing different levels of calcium intake and risk of bone stress injury. So less than 800 milligrams per day, 8 to 1500, and above 1500 milligrams. So to put that into context, national recommendations, depending on age, are 1000 to 1300 milligrams per day. So we can see a 5-fold increase in incidence of bone stress injury when calcium intakes less than 800 milligrams per day compared to greater than 1500 milligrams. So again, minimum standard meeting the national requirements, and then likely those that are at greater risk or already have a bone stress injury, we're aiming for greater than 1500 milligrams of calcium. Study on the right-hand side, so this was a study of military recruits supplemented in the intervention group with 2000 milligrams of calcium, 800 international units of vitamin D versus control, and they saw a 20% reduced incidence in the intervention group of bone stress injury. Some extra analysis they did in this study, though, is that they did some extra univariate analysis, and when they controlled for the intervention, it was actually amenorrhea that increased incidence by 83%. So I guess it comes back to, again, the role of energy availability as our first priority, and within that ensuring that micronutrient, macronutrient intake is sufficient. Pre-exercise calcium. So this is probably one of the biggest studies that's come out in the nutrition discipline the last couple of years. So Bron Lundy works with Australian Rowing. As a part of her PhD, she did a study looking at 10 milligrams of calcium versus 1000 milligrams of calcium in the 2 hours pre-exercise. And there were 2 sessions across the day, measured different markers at 10 different time points across the day. Key findings on bone turnover markers. So we saw a decrease in CTX from baseline to exercise session 1. So you can see that with the first red arrow on the left-hand side. And that was in both groups. So not surprising. So even though the meal for the control group didn't have sufficient calcium, it was just the meal in itself, because we know that as soon as you consume a meal, it's the appetite hormone response that then also has an impact on the CTX. For the remainder of the day, in the control group, we saw a pronounced increase in CTX over each exercise session. That's the 2 green arrows. But in the calcium group, CTX was maintained across those exercise sessions. And energy availability and hormones. So I wanted to really touch on the dose response of energy availability, because again, for me, from a practical point of view, this really comes to light in my actual day-to-day practice. So the figure on the right shows us changes in bone turnover markers at different levels of energy availability. We can see bone formation was suppressed even at higher levels of energy availability, so even from around that upper cutoff of 40 to 45 kilocalories. But bone resorption was only impacted at more extreme energy availabilities, less than 20 kilocalories. So that balance toward more resorption may not actually occur until we hit more extreme low energy availability. That aligned really nicely with ovarian suppression, as shown by a decrease in estrogen, so maintained, and then a decrease in estrogen from 20 kilocalories less. And that was just secondary to a reduction in luteinizing hormone pulse frequency. So how do we restore hormone levels, menstrual function in females? And apologies, I've only got a female study here. There is a lot more research done in females than males, but again, just due to time. So does increasing energy availability improve menstrual cycle function? So the Refuel study randomized normal menstrual cycle, amenorrheic, oligomenorrheic individuals to either intervention group with 20 to 40% energy surplus. 40% was the end goal. They started at 20% and essentially built up over time, compared to control group with no energy surplus over a 12-month period. We saw improved menstrual function in 64% of individuals in the intervention group compared to 19% in the control. And the figure at the bottom shows that really nicely. So the red lines are the women in the study that started with amenorrhea or abnormal menstrual function, and then the events or the menses are shown by the solid red squares. So we can see in the intervention group on the left, we've got far more events over that 12-month period in those who started with abnormal menstrual function compared to the control group. So moral to the story, we're probably going to be focusing on energy availability first, and then quality of intake. Are they meeting their calcium and vitamin D requirements after that? That's it from me. Oh, yes.
Hey everyone, I'm Kelly. Now I must preface, this is usually my bedtime, so bear with me. Okay, so I'm going to talk about management today, but I did just want to touch on the physio key role, but also the chiropractors, GPs, osteos, the people in the room who are usually those first contact practitioners who are picking up these injuries. I think we always need to have our antennas up when we are treating runners to be on the alert for the possibility that we could be dealing with a bone stress injury, because it's often going to be us to be asking a lot of those really good questions, identifying some of those potential risk factors, and then therefore being able to make those appropriate referrals to sports doctors, to dietitians, psychology, GP, whoever is necessary. But as mentioned, today I'm going to be speaking mostly to how we can complete the rehab. So it is more than just a return to running program when we're dealing with bone stress injuries. So what are the other elements that we need to be considering? All right, so we've been diagnosed with a bone stress injury. What do we do now? Or our patient has, rather. So it might be on us to be deciding what the weight-bearing status is for the person. Now, as Ross mentioned, the high-risk sites are quite tricky. It is a long period where they are going to be completely offloading that, 4 to 6 weeks, probably sometimes even more, or potentially going down that surgical pathway. So I'm not going to talk too much to that. In those low-risk sites, again, similar to what Ross did touch on, we're essentially deloading people just below the level of their symptoms. So if they're pain-free while they're walking, then they can continue full weight-bearing. They don't need to be offloaded with a boot or crutches. If they are still painful with walking, then we might be looking at offloading them with either crutches or a boot, potentially even just manipulating footwear, incorporating orthotics, getting some help from our podiatry friends for that. Now, we can pretty much be testing them every 2 to 3 days to see if they become pain-free with full weight bearing, and then at that point we can essentially disregard any of those crutches or boots or whatever we might be using for them. So as Ross mentioned, we want to be trying to get away from that kind of as quickly as we can. And with those low-risk sites with good potential for them to heal quite well, we probably have the scope to push that along as soon as we can based on symptoms. This is something that I find really interesting and something that I think is a really important part of managing bone stress injuries in particular. So if your patient has been diagnosed with a bone stress injury, there's a 600% increased chance that they are going to get another one in the future. So we want to be throwing everything at it to try and minimise the risk of this happening again for them and trying to really optimise their outcomes. So we've all seen those patients and commonly runners where they get injured, they offload completely, they lose tissue capacity, they might return to running or their activity too quickly, and then they follow this cycle again. So what sort of things can we be implementing during this offloading period and during their return to running process to try and stop this cycle from occurring? So cross-training is one of them. So cross-training throughout the injury is really important. It's actually going to encourage a quicker return to running in a lot of patients as well. There's also the obvious benefits like maintaining fitness and having general exercise benefits, very psychologically important for many runners, as Ross touched on. If you told them to stop, a lot of people wouldn't cope, or they'd probably go find someone else to talk to about that. And I think it really is on us to be asking those good questions about why they run. And I'm referencing running because it is probably the most common space, but any running or impact-based sport. So for example, if you're dealing with a patient who runs to get outside, or they do it for social reasons or to get away from the kids, then you're probably not going to just be sitting them up inside on a Zwift. That's not going to be ticking those boxes for them. So you're going to be trying to work with them to find the most suitable option for them during this time off. Some really important considerations though is that if this person is dealing with REDS or low energy availability, it's not going to be helpful for them to just be completely supplementing their running volume for cross-training volume. So their cross-training is still going to be keeping them in an energy deficit if those other factors haven't been addressed appropriately. So that can actually prolong their recovery. So we might be putting some restrictions in place about how much cross-training they might be doing. So we know the obvious options, the bike, the swim, elliptical, deep water running. Something that I've taken it upon myself to learn a little bit more about is anti-gravity treadmills. I know that that's a sort of an emerging topic and something that I personally hadn't explored much, so I was interested to learn a little bit about it. So we'll talk about that in a second. It is important though that whatever cross-training option you're choosing, it should be pain-free during, after and the next day, or it must be pain-free rather. So anti-gravity treadmills, there's no randomised controlled trials on using them for bone stress injuries. There is one pilot case study on the use of it for a pelvic bone stress injury in an elite runner, and this particular runner had a really positive outcome. So perhaps for those elite runners who have a time pressure to get back to a sport, that could be a useful reference to follow through. There is some literature looking into anti-gravity treadmills in the management of acute fractures, acute tibia fractures and post-Achilles repair, and it essentially didn't show a huge difference in using the anti-gravity treadmill opposed to just using ground running. There is a clinical commentary by Stuart Warden, the 2014 paper, which does discuss using an anti-gravity treadmill. And essentially the recommendation is that you can start to incorporate it once the person is pain-free walking for about 1 week. Now, we'll get into this shortly, but ultimately at that stage we can actually start them to begin running on ground anyway. So I think it's sort of weighing up who the person is going to benefit most from, because logistically it can sometimes hard to be implementing the anti-gravity treadmill. Something that I find really interesting and where we can have a really good effect with our bone stress injury patients is in resistance training and plyometrics. So again, this is something that Ross touched on. So we can have a very obvious impact on how our bone is getting stronger and having an impact on our bone density through the incorporation of resistance training and plyometrics, and we'll get into that shortly. Some of the less obvious reasons to be incorporating resistance training and plyometrics is, as we mentioned before, there is a 6-fold increase in future bone stress injury risk. There's contralateral bone mineral density loss and prolonged bone mineral density loss as well. So there's a couple of studies that show that there is bone mineral density loss at its lowest 20 weeks post bone stress injury diagnosis. So that might essentially just mean to us that we do need to be following through with these patients for an extended period of time, not just that 6-week period to get them back to 30 minutes of jogging. There are some discrepancies in those studies though, so take with that what you will. Essentially we can start resistance training on the contralateral limb from day 0, and I think that that's a really good idea for that reason. If we are having contralateral bone mineral density loss, then we should be starting to, or at least maintaining whatever strength and capacity that we have on the contralateral side. On the affected side, somewhere around that 2-week mark in those low-risk bone injury sites. Now, I've included this really useful slide from Dr. Richard Willey's course, which I attended last year. Essentially, it just demonstrates that if you've got a person walking for weight bearing, you can essentially have them doing single leg calf raises from the ground, and that's equivalent roughly load to walking. So there are things that you can be implementing at the time that they are beginning to walk, just to try to maintain that tissue capacity and essentially just bridge a gap from what they're currently doing to their end goal, which might be running, jumping, whatever it might be. But you can't bone build your way through LEA. So there is a study looking at military personnel, following them through an 8-week training program, and the underfueled military person actually lost bone mineral density despite their training program compared to the fueled military person. So again, everything that Beck just went through, if you've identified your patient as having REDS or low energy availability, you're not going to be able to overcome that with some squats. So what are the general principles for bone adaptation? So again, Ross touched on this previously. There is a really good study, it's an old study from 1998 by Turner, which talks about the 3 rules to bone adaptation. So essentially, rule number 1 is that it's a strong muscle contraction that's going to be the most osteogenic effect. If we can add in some speed to that, then it's going to be even more effective. Rule number 2 is that bone desensitizes to mechanical load. So after a repeated repetition, so after quite a lot of volume, it's become somewhat numb to that stimulus. So we're prioritizing intensity over volume. And number 3 is that essentially bone gets bored of routine loading. So bone stimulus needs to essentially be error-driven or multi-directional. So if we can incorporate that, that would be really good. So the clinical application for that is essentially trying to get your patient into the gym if possible, or finding an intensity that is challenging enough for them to keep the volume low but the intensity quite high. So axial loading is going to be best to get the best bone stimulus, and we want to be making it heavy to get that really strong muscle contraction. So it doesn't need to be anything super complex. Some axial loaded exercises, a back squat, a deadlift, a lunge, a single leg calf raise. Having your patient do that a couple of times a week could be a really good starting point, or maybe later down the track, not straight away. Rule number 2, as mentioned, the bone becomes numb to our stimulus. Most adaptation occurs between 20 to 60 loading cycles, but after about 100 loading cycles, that stimulus essentially starts to just diminish. So what's the clinical application to that? So incorporating some plyometric exercises and potentially putting them at the start of a gym session so your bone is getting the most out of it. If your runner is considering doing strength training and running on the same day, then you might be educating them on incorporating the strength training first, or giving them about 4 to 8 hours for that bone to resensitize before you're giving them that really high osteogenic loading. Rule number 3, as mentioned, bone adaptation is error-driven. Now, I think that this is a really important principle, particularly when we're dealing with our adolescent athletes. So if we can keep our adolescent athletes in some form of team-based sports for as long as possible and avoid that early sports specialization, then that can be a really effective way to try and encourage that multi-directional stress. There's intensity there's change of direction. All of those types of things are going to be really helpful for those adolescent athletes. When we're talking about our adult athletes, then you can essentially do everything that we just talked about, but add some side-to-side movement. So skater jumps, triple crossover hops, all of those sorts of things, just to get a little bit of variability into the program as well. So talking about return to running, and I'm going to keep this focused on the low-risk sites. When your patient has become pain-free with walking and activities of daily living for 1 week, that's when we can start to have that conversation about beginning that return to running program. So the first thing that they need to be able to tick off the list is 30 minutes of pain-free walking. If they can carry that through for 5 to 7 days with a day off in between and no increase in their symptoms, then at that point you can start to begin their return to running program. Now, it needs to be really important that we're educating our patients on the intensity of these walk-run intervals. So obviously we're going to be starting with a smaller dose of running to begin with. That doesn't mean a very fast 1-minute interval. That means a jog at about 50% of their regular jogging speed. I'll touch on how to then sort of move in the performance direction and incorporate intensity a little bit later down the track. Now, the Stuart Warden paper from 2014 has a really nice recipe to follow. I think that this is essentially a framework that you can use and then adapt it to the person in front of you. So returning to run is a little bit more of an art than a science. We need to be considering the person in front of us. So asking yourself the question, have they been down this route before where they've dealt with multiple bone stress injuries in the past? Are they dealing with REDs, or do they have any other risk factors? Have you identified that there is some sort of deficit in strength or some biomechanical reason that they could be putting particular stress in that area that has been affected? And then they're the things that you might be manipulating when you are structuring that return to running program with the person in front of you. Now, some other things that you can consider, so load modifiers when we are starting to think about running again. So there's a few little questions in here to ask yourself. So would your runner essentially be putting more stress on their plantar flexors, so their tibias, their metatarsals, when they're jogging slowly or when they're running quickly? Pretty obvious, we all know that, maybe? So when they're running faster, it's going to be putting more load. The less load is going to be jogging slower. Ross touched on this one previously, so hopefully we were all listening. So if you have a cadence of 175 beats per minute versus 155 beats per minute, which one is going to be putting or reducing load on our plantar flexors? Higher, yay! Again, Ross touched on this too, so hopefully we were listening again. So running in barefoot shoes or running in shoes with a higher heel to toe drop, what is going to be reducing our plantar flexor loads? High heels, perfect. Overstriding or landing with our foot closer towards our center of mass? Foot closer, cool. And then I feel like this is quite an interesting one because I hear conflicting things in the running space about this. I often hear people saying that, I'm giving this away now, but running uphill is going to be reducing the load on their bones. But as we touched on before, bone stimulus is driven by a stronger muscle contraction. So running uphill is generally going to be a lot harder for our plantar flexors. So therefore it's going to be stressing our tibia, our metatarsals that little bit further. So running on flat is a lot easier for our plantar flexors. Alrighty, so returning to performance. So as mentioned, it is more than just a return to running program and your runner is at 30 minutes of jogging. How do we then get them back to performance? So commonly the runner who has sustained a bone stress injury probably has some goals to get back to a higher level of running than just 30 minutes of jogging. So some important things that we need to be considering and educating our patients on is that bone loading is going to be significantly increased as we start to run quicker. So intensity distribution really does need to be discussed and it needs to be managed in some way. So it is recommended the safest way or the way to reduce the risk mostly would probably be to reduce the volume while you're adding in intensity or any sort of uphill running if we are dealing with any of the tibias, fibulas, plantar flexors, anything that's going to be really involving those plantar flexor forces in particular. The other thing that I think is a really important conversation to be having is the importance of down weeks or deload weeks. So there is a study, again, looking at the military group, showing that the incidence of bone stress injuries tends to occur about 3 to 8 weeks post-spike in training load. So perhaps if we can be educating our patients to be taking down weeks every sort of 3 to 4 weeks to give the bones a chance to almost catch up to that training load, then maybe that might be a way to help minimize the risk of these happening in the future as well. So adjuncts exist, but that doesn't necessarily mean that we have to use them. As Ross touched on as well, there's minimal evidence to support the use of these therapies. I think that there is so many key education points that we can be covering with our patients, whether it be on load management, deload weeks, footwear, surfaces, energy availability, all of those sorts of things. During the time we spend with our patients, running analysis, strength testing, plyometric testing, establishing strength and conditioning programs. So there's so many elements that time can be spent or better spent. If there is a space for this, as Ross mentioned, there might be a little bit of evidence in acute fracture management for low intensity pulsed ultrasound, but RCTs don't seem to show that in the management of bone stress injuries. Blood flow restriction training might be better than low intensity training. However, again, as you can imagine, bone load comes from a really strong muscle contraction that needs to be against some sort of heavy resistance, and the idea of blood flow restriction training is to essentially eliminate the need for a really strong muscle contraction. So that's not that great. And manual therapy, as it says, if running isn't a great bone building stimulus, then your hands probably aren't going to be either. So take with that what you will.